So our plan is in a way that whichever blocks they are going to demonstrate live will take you through either prior or post block the master scan so that it helps you in doing it in day-to-day practice. So anybody practicing lumbosacral plexus block? Can you, anybody? Okay, only scanning. Fair enough. So lumbar plexus is formed by the fusion of L1, 2, 3, 4. And the moment the roots exit out of their intervertebral foramen, they travel into a lumbar paravertebral space and subsequently get inside the psoas major. At the junction of anterior 2/3 and posterior 1/3, the formation of the plexus takes place. This much is clear to everyone? So there are three classical approaches of the ultrasound guided lumbar plexus block. Number one is the paramedian parasagittal through lumbar ultrasound trident, described by Dr. Karmakar and colleagues in 2008. Then came the shamrock approach, described by Axel Sauter and colleagues in 2013. And subsequently, Dr. Manoj Karmakar modified his own approach as paramedian transverse scan. Out of these three approaches, the best approach is the shamrock approach, which I'll be showing you right now. Now coming on to the sacral plexus. So the formation of the sacral plexus takes place inside the pelvis. Is this visible? So it has to come out because it has to supply the posterior half of the body. So how does it come out? It comes out through the greater sciatic notch. Recollect from anatomy days, we were asked a question that what are the structures which come out through the greater sciatic notch above the piriformis and below the piriformis. So piriformis muscle fills the greater sciatic notch, which we are able to visualize. Anterior to that, if I'm looking from the posterior aspect, that means deeper to that is the sacral plexus which is located. So this is how I'm going to demonstrate the lumbar plexus through shamrock approach and the sacral plexus at the level of greater sciatic notch. Is the anatomical concept clear? Can I move on to the volunteer or any questions up till now as regards anatomical concept? Okay. So in order to perform these blocks, the patient has to be lateral decubitus. He is a well-built, almost, what is your weight like? Kitna, wazan kitna aapka? 70 kg. So we are not showing you the ideal lean and thin kind of a person. We are showing you what we encounter in our day-to-day practice. Okay? So the individual volunteer or the patient has to be in lateral decubitus position. The machine has to be in front of me, and I'm going to use a curvilinear probe because these are deeper structures. So what we are going to use is Sonosite PX machine, which is a Mercedes-Benz I call, because the resolution is too good. So initial probe placement for shamrock technique for quadratus lumborum or for that matter lumbar plexus is between iliac crest. I am feeling the iliac crest and the costal margin. So can you focus the camera person? Yes. So I'm going to place my probe in between these two structures. So can you see the depth? Okay. So can I get the laser pointer? Ek aur depth bada. Okay. So left hand of the screen, my dear friends, is anterior. Right hand of the screen is posterior. So right now I am on the nerve preset. I would request Srikanth, he is from the Sonosite, to switch over to MSK. So musculoskeletal can give us much better. So I am applying considerable degree of pressure. Can you increase the depth one more? So are you able to identify the shamrock sign? This is the vertebral body, this is the transverse process, this is the psoas major, this is the quadratus lumborum, and I move anteriorly. Can you see the external oblique, internal and transversus oblique? So I am applying considerable degree of pressure. Okay, right now I am seeing the transverse process view of the shamrock. Lumbar plexus is situated somewhere here. So my needle can come from this place or this place, but what will happen? I'll hit the transverse process. So what do I need to do to avoid the transverse process? I'll need to tilt my probe slightly cranial or caudal so that the transverse process gets bypassed. Now is it bypassed? Can you visualize? Okay. Now is it bypassed? Yes. So what I am seeing, this white hyperechoic structure would represent very well the lumbar plexus. But in order for me to confidently say it is lumbar plexus, what do I need to do? I need to use a dual guidance, that means a peripheral nerve stimulator along with it. And if you closely observe this place, you might observe certain pulsations. These are pulsations of dorsal branch of the lumbar artery. So we might get in our needle path. So this is the cause for retroperitoneal hematomas. So a good knowledge of the anatomy, a good resolution machine helps you in identifying the vessels and avoiding complications. So from where my needle is going to come? So my needle is going to come, I'm going to calculate the distance. The distance of the lumbar plexus close to is 8 centimeter. So I will measure 8 centimeter and then my needle is going to come from this place. आप इस तरफ focus करेंगे? हाँ, एक second. So my needle is going to come from this place. Can you see my needle trajectory? Manish, ऊपर वाला point करना. Picture in picture वाले में. Yes. So I'll measure 8 centimeters from this place and enter. Or alternatively, I can enter from this place. Okay. So, but this will be quite oblique trajectory. So once again, we'll go back to the image. Can you see the classical, can I have the ultrasound screen, please? I am seeing the classical transverse process. Slide till the transverse process is gone, and this is the lumbar plexus. So my needle will come from this place or this place, and the drug distribution will happen like this. So we are supposed to deposit in the posterior medial quadrant and 15 to 20 ml of the drug. 0.5% ropivacaine for anesthesia and 0.2% ropivacaine for analgesia. Is this clear? So moving on to sacral plexus. So as I said, sacral plexus exits from the greater sciatic notch. So the approach which has been described is known as parasacral parallel shift. Thereby meaning, first I'll feel, isko bada screen kar do. I'll feel, first I'll feel for the most prominent process of the iliac crest, that is the posterior superior iliac spine. Okay. Next, I'm going to feel for the greater trochanter. So how do you recognize that this is the greater trochanter, my dear friends? Slide your hand onto the lateral aspect of your thigh. As you move upwards towards the hip joint, the most prominent point is your greater trochanter. So if I draw a line in between these two and bisect it, on the medial half, if I keep my probe, my dear friends, I'll be visualizing the ala of the ilium with three muscles, gluteus maximus, medius and minimus. So can I have jelly, please? Yeah. So आप इस पे focus कीजिए. Okay. So right now this is the posterior superior iliac spine. This is the greater trochanter, my dear friends. I am drawing a line like this from PSIS to GT. Okay, my dear friends. Next, I'll bisect this line and keep my probe on this bone. So what I will visualize is the ala of ilium and the three muscles. As I move downwards towards the midline in inframedial direction, I'll visualize a break. What is that break? Break reflects the greater sciatic notch, and anterior to the pelvis, that is deeper to the piriformis muscle, we would visualize the sacral plexus. So can I have jelly, please? Okay. So left hand of the screen, my dear friends, is going to be medial. Can I have the ultrasound screen? So left hand of the screen is medial, right hand is lateral. Can you see what is this? Ala of the ilium. We see the three muscles, gluteus maximus, medius and minimus. Is this clear up till now? If a yes or no would help me, because whether I am proceeding fast or slow, I need to know. So maximus, medius, minimus, everybody is going to, is okay with that? Can you see the pulsation of this vessel? These are superior gluteal vessels, and next to the superior gluteal vessels is the superior gluteal nerve. So the next important aspect is I have to move my probe towards the midline, inframedially, and I'll try to visualize the break. As I move inframedially, my dear friends, can you see the break happening? So this bone on the lateral side is the posterior border of the ischium, my dear friends. This bone which you see is the ilium, and the plexus is beautifully seen. Can you appreciate the plexus? And can you appreciate a vessel pulsating here? This vessel is inferior gluteal artery, which is medial to the plexus. The hypoechoic muscle on top of it, ultrasound screen please. The hypoechoic muscle on top of the bony prominence is the piriformis. How do I say it's piriformis? I'll ask him to rotate his limb like this. Can you see movements happening? So which helps me to identify this is piriformis, whereas it is not possible in case of fractured limbs. Please do not do that. This is just to impress upon you that whatever muscle I am showing you, it belongs to the piriformis. So what is this? The plexus. So plexus is situated almost at 9 centimeters. He's a robust guy, 70 kg. So what do I need to do? I get my needle from the lateral side, my dear friends, here, go up till this point and use the dual guidance, that is peripheral nerve stimulator along with it. I'll get the hamstring twitch or the dorsiflexion or the plantar flexion. Is this concept clear? And we'll start with 1.5 milliamperes, drop till 0.4 to 0.3 milliamperes. Again, 15 to 20 mLs of the drug is required to produce anesthesia. For anesthesia, we'll use 0.5% ropivacaine. For analgesia, we're going to use 0.2% ropivacaine. Alternatively, if you are not able to see the posterior superior iliac spine, which is unlikely, Ahmed Ta in 2012 said, you can easily visualize the highest point of your gluteal cleft. Yahan focus kijiye, please. No. Gluteal cleft is visualized in each and every individual. So you look for the highest point of gluteal cleft, measure 8 centimeters, and keep your probe transversely. Okay. Again, the same picture. Can you see the ala of the ilium? Like a mountain, on top of that gluteus maximus, medius, minimus, a pulsation C. Next step is again, I'll try to move caudally to identify the break. So I'm moving caudally, my dear friends, I'm moving caudally. Can you identify? I have moved caudally, okay? So slight caudal tilt is going to help. So this is the posterior border of the ischium, like a parrot beak. The plexus is seen here. So which approach is giving you better plexus visualization? In this case, the parasacral parallel shift. Observe both the approaches, the Taha's approach as well as parasacral parallel shift. Whichever gives you the good visualization, you can perform the block in that. So I'm trying my level best. So I think the previous image was much better. Now it has come much more closer to the bone. So for analgesia, what we recommend is do not go close to the sacral plexus. In 2020, Madan Narayan and Venkata Raju stated that all the nerves in the body are situated in musculofacial planes. So a good technique would be, instead of coming close to the plexus, come close to the edge of posterior border of the ischium, deposit 20 mLs, the drug would flood the sacral plexus. So up till now, I have told you 3 approaches to sacral plexus. The parasacral parallel shift, can we have this as a bigger screen? Again, I'll explain. Then the Taha's approach, and the parasacral ischial plane block. So again, I'll explain till the time they are on. So the individual is lying like this. The pelvis model is okay to you. You can visualize. So what is this point? Superior iliac spine. What is this? GT. If I draw a line and bisect it medial to the bisection point, if I keep my probe medially, what is that approach? Parasacral parallel shift approach described by Bernstein et al. I'll visualize the ala of the ilium, 3 muscles, again move downward towards the midline. I'll visualize the break. What is that break? Greater sciatic notch. The lateral boundary of the greater sciatic notch, my dear friends, is the PBI, posterior border of the ischium, which has got a parrot beak appearance. Is it clear? The medial border articulates with the sacrum, so it is a part of ilium. Alternatively, the highest point of the gluteal cleft, my dear friends, is visible to everyone. Just take 8 centimeters from that. You place your probe like this. Again, you will be at the ala of the ilium. Again, the job is to move your probe like this. Again, you will visualize the break in the ilium. What is that break in the ilium? The greater sciatic notch. Or alternatively, you can do as an interfacial plane block, deposit the drug at the edge of the posterior border of the ischium. Because the plexus is lying just anterior to the piriformis, the drug will seep towards it. So any questions up till now as regards lumbar plexus and sacral plexus? So some of the tips and tricks I would like to give you for lumbar plexus. We have to start with a current of 1.5 milliamperes. Okay. What are we looking at? The quadriceps dance. Okay. In the psoas major at the junction of anterior 2/3 and posterior 1/3, medial most is the obturator nerve. then would be femoral nerve, and the lateral most would be LFCN. So a question should come in your mind that why I am not looking for a obturator twitch rather than a femoral twitch. Does it come to your mind? What is the answer for that? Because obturator is located in a medial most compartment. At times anatomical variations are there. It might be located not perfectly in anterior 2/3, posterior 1/3 in a separate intramuscular fold. What is most consistent in that compartment, the psoas compartment, is the location of the femoral nerve. So what we are doing is we are trying to stimulate the femoral nerve and observing for the quadriceps twitch. From 1.5 milliamperes, I'll keep dropping my current till 0.4. At 0.3, if I'm getting a twitch, that means I could be intraneural, both for sacral plexus and lumbar plexus. What I need to do is slightly withdraw my needle, just a millimeter or so. Is this concept clear? Lumbar plexus, my dear friends, if you can see for yourself, is very close to the neuraxis. The lumbar nerve roots are coming like this. It's very close to the neuraxis. So what happens is, for a short distance, the nerve roots are covered by the dura. If I am too much medial, my needle tip can be just outside the dura. I'm depositing 20 mLs. The drug can become epidural. So 3 to 27% of the cases of lumbar plexus will have epidural diffusion of the drug. How will you come to know clinically? You will get a bilateral effect. You have given a lumbar plexus on the right side. If you get a bilateral effect, आपको पता चल जाना चाहिए कि the drug has diffused into the epidural space. If you are inside the dural sleeve, you would be in the subarachnoid space. Just Google it out, total spinal following lumbar plexus. Good number of case reports are there. 3-4 years back, a case report has been there from AIIMS, New Delhi also. So the problem with these blocks are, these are very deep blocks, both of them, cannot be done in patients who are on anticoagulants, okay? Number two, you have to be very careful. As regards both of them, last is possible because you are working very close to the vessels, particularly in lumbar plexus, as I showed you. They are ready? Okay, so they are ready. So let's have a live demonstration of lumbosacral plexus, and afterwards we'll keep taking questions from you. एक माइक हमें दे देना.
Hello, Dr. Divesh, can you hear me?
Yes, sir, we can hear you, sir.
Please go ahead, Dr. Anshuman.
Yeah, thank you. The first patient that we have is a lumbar sacral plexus block patient. So I'll be handing over the mic to Dr. Jasmeet to give a detailed information about the patient. Just that the patient is not a very good patient on clinical grounds. He has multiple